model is moving from a traditional model that's based on visits and based on procedures to something driven by healthcare reform, but really driven by other factors as well, to create a virtual experience where, for the 140-year history of UH, the model has really been about, can we create a procedure, can we do something to someone, and if we show evidence that we've in fact done that, can we receive payment for it? So for example, hip replacement. So if we can successfully complete a hip replacement, show that certain individuals spend time on that, we use certain supplies, and the patient who's in our facility, a turnstile moves, and payment's ready for that service. Where we are headed is something very different, which is measuring the outcomes and the true experience and what's called the continuum of care. So not that the procedure was performed, but was it successful? And success can be measured a number of ways by, was there potentially a readmission? So did you have to come back another 2 weeks because of something that maybe didn't go properly? Did you have a secondary infection? Were you not able to return to work in a timely fashion? Did you have something that happened maybe months or years down the road? All these things today represent individual incidents and episodes that make those turnstiles move again. But in the future, this concept is going to lead this model to be outreach, to be engaging populations, or really putting accountability and engagement throughout the continuum of care to the forefront. And what I mean by that is, in order for university hospitals or other providers to continue to exist and thrive in a post-healthcare reform environment, we all have to care about what happens beyond the hospital doors. We all have to be concerned with not just the patient's immediate well-being, but their overall health and their overall wellness. And the key to that is going to be patient engagement, moving to a model of patient accountability, and the market around telehealth. So having equipment and devices in people's homes, in settings outside of traditional care, today is about a $163 million market. By 2010, it's forecasted to be over $1 billion. And this is really the growth in things today are more traditional, such as blood pressure monitors, weight scales, glucose meters, medication dosing equipment that can all be placed into the home and then monitored remotely. So again, making sure that the patient, for example, using hip replacement, let's make sure that we can measure, is the patient following the protocol when they go back home? Are they moving properly? Are they getting the care that they need? More so than just perhaps having a visiting nurse attend to the home, but having equipment and telehealth equipment that can monitor that and report back, so that, again, we can monitor that continuum of care. This environment's going to move on to much more sophisticated types of equipment, such as heart rate, respiration, movement sensors, things that can be equipped in the home to sense, for example, when someone might have fallen, or equip the home to sense when someone's sleeping, sort of their resting, respiration, their heart rate, and other factors that can all be used to create data that ends up in this circle to create a wider accountability for the experience of healthcare. So I think in terms of where broadband, where delivering more connectivity to America and the communities that we serve, this is incredibly important. University hospitals needs this, need you. Say healthcare needs this as well. And there's going to be a tremendous opportunity for us all to thrive and engage our patients and our communities in this process. And another thing that I'll close with is that this circle is also a tremendous generator of data, a prodigious generator of things like images and bits and all those things as a chief technology officer that I'm very concerned about the growing need for. So something that's also an imperative for us is to engage in collaborative models around shared services and creating economies of scale and recognizing that the data that gets created from this process is not ours. This is not University Hospitals data. This is our patients' data. This is something that should be owned by the patients and owned by the populations for your lifetime, because this data will be around for a long time. And what we want to do through our strategies is to ensure that it moves to a model that facilitates that and makes that easier as healthcare reforms and our priorities change. So,
thanks, Brett.